But anyway, it is 10 o'clock, so I don't want to waste anyone's time. We'll jump right in here. So if you weren't here earlier, my name is Chelsea Smith. I am your one and only learning and development specialist here in Action Benefits. And today I am joined with my friend Renee as we talk to you about Medicare fundamentals. Renee, give the audience what they want.
Good morning, everyone. Thank you so much for joining us today. I am one of the account managers on the individual team, and we are here to help. So if you have any questions, if you are in need of supplies, or again, we're here to help. So reach out to our team, and we're happy to answer your questions.
Awesome. Thank you, Renee. So if you do have any questions throughout our presentation here today, please feel free to put them into the chat, and Renee or myself will get to the question as soon as we can. But without further ado, let's go ahead and get started. This is one of the heftiest webinars I give, so I'm going to try. I always try really hard to start and end on time. So I'm holding myself to that, and you hold me to that too. Okay, so what we're going to try to get out of today is define the parts of original Medicare, identify ways to supplement, there we go, original Medicare, and describe pathways for clients to enroll in Medicare. And that sounds really broad and basic, and like that should take us 10 minutes. It's going to take us the whole time, guys, so buckle in. Okay, so the last couple of times I've done a Zoom webinar, the Zoom quiz and poll thing has been kind of not working as well as I'd like it to. It's been displaying wrong stuff lately. So you could be so kind as to, instead of using the Zoom poll thing I normally have you use, put in the chat. And remember, in the chat as well, I've set it to automatically send questions only to me. So if you would like to have your question displayed to everyone, please make sure to switch it to everyone. But if you could type in the chat, which of these statements best describe you in your Medicare journey, I would greatly appreciate it. So some of you might be completely new to this market. Some of you might have some experience with us, but not necessarily experience with the market. Vice versa, might have experience with the market, not experience with us. Or you just really like hanging out with us. In that case, awesome, love you, glad you're here. So if you could be so kind as to put that in the chat for me, which one of these best represents you, that way I know how much time to spend on maybe more basic elements if we have newbies to the crowd, or if we are really experienced and you're going to want to spend some more time on the more nitty gritty. That way I know where to go here. So I'm not boring you with some details that aren't relevant. So it looks like, based on my host and panelist chat, we have some more seasoned people than usual here, or just people who are looking to refresh, and that's totally awesome. That is what I'm here for. So glad that you're here, and thank you for spending some time with me today. And of course, put your questions in the chat as you have them. So first, we'll start with defining Medicare. And if you know me or seen me do this before, you know this is interesting to me. I love history stuff. So while this stuff isn't particularly easy, it is easy if you kind of, maybe the background can kind of help you out a little bit. So we take some of a deeper dive into some of these topics in other webinars, and have some recordings ready for you to watch on YouTube of some of those webinars if you so choose. But for now, we're going to stay way high up. And then if you have questions deeper in, let me know. Or if you are interested in your own time to get deeper in, you can go ahead and do that in the webinars recordings on YouTube. So back in July 30th, 1965, President Lyndon B. Johnson signed the Medicare and Medicaid Act into law. The law established Medicare Part A to cover inpatient services with other things like hospital stays and skilled nursing facilities. And then Part B to cover outpatient services. So think like going to your doctor, going to a specialist, and getting preventative care. Medicare is available to those who are 65 and older, those with disabilities, and those with end-stage renal disease, or as you might hear it called more often in shorthand form, ESRD. Most of it is people who are over 65, but they are not the only people who can have Medicare. So usually you'll see, like creative targeted for over 65, but not necessarily always the case that it's only under 65. Or I'm sorry, over 65. Okay, but the people wanted more. So Congress updated the legislation over the years to allow supplemental policies to be provided by private carriers for purchase by consumers. These policies offered additional items like travel emergencies, provide financial support to cover deductibles and coinsurance, and depending on what type of supplemental coverage you're looking for. So for those of you who might be familiar with this stuff already, this is going to sound familiar. These are medigap policies, right? So these plans became standardized in the Consolidated Omnibus Reconciliation Act of 1990, which some of you might recognize in its more shortened form, COBRA, and went into effect in 1992. But you haven't heard anything about drug coverage yet, and that's because Congress did not address drug coverage for those with Medicare until the Medicare Modernization Act of 2003, which allowed private carriers to begin issuing Part D for drug policies in 2006. But Chelsea, the alphabet doesn't go A, B, D, it goes A, B, C, D. I know. So that's where this comes in. So in 1997, Congress passed legislation to allow private carriers to enter the senior market. And at that time, those plans were called Medicare Choice Plans. So if you ever hear someone use that phrase, they mean Medicare Advantage. Because they gave the consumers the choice between the public option, which we now know as Original Medicare, and the private option, which, like I said, we now usually know as Medicare Advantage. So these plans combined A, B, and usually D, not always, but usually they have D to Part D as well. And they embed other additional benefits sometimes also, such as like dental, vision, hearing, stuff like that. There's also supplemental benefits within Medicare Advantage plans like silver sneakers, transportation, so on and so forth. But that's getting kind of deep. We'll go back to that later. So there are 5 distinct programs that seniors could be eligible for, but a variety of legislation and rules governs the way that these programs can work together. So generally speaking, a beneficiary will always enroll in parts A and B, which is also known as Original Medicare, to be eligible for any of the other programs that are available. So they'll be responsible for premiums for Part A and B. Most of the time, people don't end up paying for Part A, but we'll get into why in a minute. So don't get confused, but they'll have to pay for the premiums for these. And then after they enroll in Parts A and B, the beneficiary can enroll in either a supplement policy or a Part D prescription drug plan, or both if they want, depending on what works for them. And then they also have the option, if they have A and B, to enroll in Part C or the Medicare Advantage plan. Notice how the box went away for MedSup in Part D because you could not have a MedSup plan in a Part D plan with a Medicare Advantage plan. That's illegal. Oh, okay. So, Renee, did I miss anything?
I don't think so, Chelsea. I think those slides are great, kind of breaking down the different types of coverages in an easy, format to read. Great job.
Awesome. Thank you. Okay. Just wanted to make sure. Okay. Because that's a lot. So I know I'll go back one more time to make sure, because that is a lot. I understand. So if you're new to this, I can send the slides out if you'd like, just let me know. But if you're new to this is a good slide to kind of get you familiar with the different ways that these plans are available and the way they coordinate. Okay, so let's start with the original, the basis for Medicare. So premiums, coverages, and penalties for your Part A and your Part B. So throughout this presentation, you're going to see this pyramid that I put on your screen here in the middle-ish, because it kind of helps you understand how the different parts will work together to create your beneficiaries' benefit packages, or how they choose to put the pieces together to get the coverage that works for them. So as you can see, A and B are at the very bottom of the pyramid. That's because just about always your clients are going to have A and B. So as you can see, we have A at the bottom in red there, and I will explain Part E right now, or A right now. So usually you don't pay a monthly premium for Part A if you or your spouse paid Medicare taxes while you were working. This is why a lot of people will call Part A premium-free Part A, because most people end up not needing to pay their premiums for Part A because they worked and paid federal taxes. So the Federal Insurance Contributions Act, or FICA tax, is a U.S. federal payroll tax that is imposed on both employees and employers to fund Social Security and Medicare. You've probably heard of it. So this is why about 99% of people won't have to pay, because they've worked at least 40 quarters. I did have had questions in the past about what if someone has immigrated to the United States and did not contribute to that. They would have to pay their premium for that, most likely, unless they worked for some amount of time after they immigrated. So if they immigrated very early in their life, they probably would be okay because they would work that 40 quarters. But if you're immigrating here at like 63, you're probably going to have to pay the full Part A premium once you become a citizen and if you want to have Part A. So if you aren't eligible for premium-free Part A, like that person I just probably mentioned, you are able to buy it. You have to be 65 or older and enrolled in Part B and meet citizenship and residency requirements, as I just said. And in most cases, if you choose to do it, you would have to pay a premium. The premium is going to differ depending on how long you worked or if you worked at all at any point and paid federal taxes at any point. So Social Security determines if you have to pay that premium or not. So that premium in 2025, if you have worked less than 30 quarters, is $518 a month. And those who worked between 30 and 39 quarters would have a partial coverage of it, and that would reduce the premium to $285 per month for 2025. So you might also have to pay the premium if you are disabled and got it a little early and didn't work into it long enough. That also might be a situation for some of your clients. You might also be able to return to work and continue to contribute for up to 8.5 years after to get that premium-free Part A. If you went on Medicare because you were disabled, no longer qualified, went back on, worked again, then by the time you turn 65, you might be able to still recover and get that premium-free Part A. So keep all that stuff in mind. Again, those are such like niche situations. Most of the time people just qualify because they worked or their spouse worked long enough where they get premium-free Part A. So then, okay, Chelsea, we talked about how we pay for it. What do I get? So with Medicare Part A, or hospital insurance, as like some people call it, a lot of these have a lot of different names. They help cover medically necessary inpatient services. So things like inpatient hospital care, things like within inpatient hospital care, you get things like a semi-private room, meals, nursing, hospital services and supplies, care in inpatient rehabilitation facilities, and inpatient mental health care in a psychiatric hospital with a limit of 190 days. All people with Part A are covered for inpatient hospital care when you have all of these things. When you have a doctor make an official order saying you need, as of 2013, 2 or more midnights of medically necessary care to treat your illness or injury, and the hospital admits you formally, you need the kind of care that can be given only in a hospital, that the hospital accepts Medicare, and the utilization review committee of the hospital approves your stay while you're in the hospital. And that sounds like a whole lot, but most of the time, if you're in the hospital, you are going to the hospital, you're going to need that stuff anyway. So the other thing it covers is inpatient skilled facility care, or SNF care, which is not the same as custodial or long-term care, just so that we're clear. Skilled care involves safe and effective care given by skilled nursing or rehabilitative staff. Skilled nursing and therapy staff includes registered nurses, licensed practical vocational nurses, physical occupational therapists, speech pathologists, and stuff like that. So for you to get that covered, though, you would have to stay in the hospital at least 3 days and then be transferred to that skilled nursing facility for that to be covered. And then you got your home health care and hospice care as well. So then what is not covered is your private duty nursing, your private room in the hospital. If you want to have one of those, you can pay for it, but it's not covered. Like non-essential items within your room, like a TV and phone, if your hospital charges for that, Medicare will not cover that, you're footing the bill for that. And then personal care items that you might need while you're in the hospital, like those grippy socks or razors or shampoo, I don't know. I've never been in the hospital myself, so I don't know exactly what they give you and what they don't, but whatever is considered a personal care item, that is on you to cover. Okay, so then what are the costs for all these things? Outside of the premium. So these are the costs for 2025. If you have Part A and spend some time in the hospital, you have to pay the deductible for that first 60 days that you spend in the hospital. That deductible is for the entirety of the 60 days, not like each day within the 60 days. So you don't have to pay for 2025, it's $1,676. You do not need to pay that each day. That's just over the 60 days, if that makes sense. So if you're still in the hospital after that 61st day, your deductible is reduced, but then you pay that every day. So that $419 is the deductible for days 61 through 90, but you had to pay that $419 every day. So, oh my gosh, God forbid you are still in the hospital after that point on day 90. So after day 90, you're now dipping into your lifetime reserve days, which you get 60 of. And each day you're paying $838 of a deductible. After that, you're responsible for 100% of the costs. I hope for you and your clients that you are not in the hospital that long. The only caveat is if these days are spent in a psychiatric hospital, you only get 190. That's it. So after you leave the hospital, you might find yourself in need of additional care outside of the hospital, like we talked about in the earlier slide. You might go to a SNF or a skilled nursing facility. Your first 20 days of benefit period there is free. And at this time, we were working with co-insurances, which means you pay a flat rate per day from day 21 to 100. So there's no deductible. So you pay nothing for the first 20 days. But then after that, from day 21 to 100, you're paying $209.50 for each day. Beneficiaries pay all costs after days 100. So God forbid you're still in the skilled nursing facility. After that point, you're responsible for the time that you're there. And then you pay nothing for home health care services under Part A. Okay. So we talked about benefit periods just there. Like what does that mean? Okay, I'll tell you. So on the previous slide, we talked about those. They describe the period of time that you are in the hospital or the skilled nursing facility, plus another 60 days immediately following the day that you leave. Benefit periods are important to understand because they tell us whether or not the beneficiary is going to be responsible for paying another deductible and how much, depending on how many days they spend in the hospital and how many days happened outside of being in the hospital. Chelsea, what are you talking about? I'll show you. I just want to put it all on the screen because I think it's a little easier to understand this way. So let's take a look at a sample benefit period. Let's say that your client spends 5 days in the hospital. They'd be responsible for that deductible, that $1,676 in 2025 for that time. Then they would leave, let's say they left the hospital and they went to a skilled nursing facility for 20 days. That didn't cost them anything because the first 20 days do not have any cost sharing associated with them in a skilled nursing facility. And then let's say that they return home and they're safe and sound and it's a great time. And then 60 days later, so long as you don't wind up in the hospital again, you're out of a benefit period, or your client, I should say, is out of a benefit period. And if they need to go back to the hospital on the 61st, like 61 days later, they restart a new benefit period and have to pay that deductible again. But on say the 60th day or the 59th day, they have to go back to the hospital. They're still covered under that benefit period. They will not need to repay that $1,676 again. They would still be under that same one benefit period. So just keep in mind when your clients are looking at how much a hospital stay is going to cost, that it can sometimes depend on when you were in the hospital previous to that. can be a little cheaper for you if you're keeping those together. They're close, I guess. Okay, late enrollment penalties for Part A. This is the not so fun part. So if you aren't eligible for premium free Part A, and again, 99% of people are, but if they're not, you have to pay a monthly premium, or I guess also, I should say, if you didn't buy it when you were first eligible, if you did not sign up for premium free Part A when you were first eligible, you your monthly premium will go up 10%. And you'll have to pay that higher premium for twice the number of years you could have had Part A but didn't sign up for that. And you have to pay that for twice the number of years that you would have had it. But like I said, most people don't have this problem because 99% of us qualify for it because we or our spouse worked. So when you have your client sitting in front of you and they're asking you, should I sign up for Medicare Part A? Here's a couple questions that you could have them, that you could ask of them, or some facts you can tell them. As we said before, most people won't pay a premium for it anyway. There are some late enrollment penalties if you don't sign up when you first turn 65, but it is important to keep in mind as well that your employer health coverage can affect whether or not you need to sign up for Part A, because if someone is covered by a group health plan from an employer with fewer than 20 employees, Medicare secondary payer rules determine that Medicare is primary. So they're going to want to sign up for Part A because then they would need that coverage because Medicare would come in primary. If they have more than 20 employees in their workplace, then that group health plan is going to be primary and pay first before that Medicare coverage is going to kick in. So it's going to be important in that discovery process when you're asking these questions for your client if they need to sign up or not. It's a good idea to know how large their employer is if they're still working, and they're going to look at you crazy like, what does that have to do with me? But it does because of this situation. And then if a member is covered by individual marketplace plan, eligibility for Medicare removes the eligibility for subsidies and advanced premium tax credits. As we know, we're not sure if those are going to continue into 2026, but for now, that is a good thing to keep in mind for your clients who might really like their marketplace coverage, let's say, but don't want to pay an arm and a leg for it because they're getting subsidized. If they're missing out on that subsidy because they're turning 65, might be a good option to tell them to go immediately get Medicare. Okay, Renee, is there anything I missed?
Chelsea, actually, this is a great slide. So it's really important for the member to know if they're aging into Medicare, what work with their agent, what size employer do they work for, so that their coordination of benefits will all work out. If not, sometimes that can be on the back end a little bit of a headache because the way the claims are processed, who pays primary, who's secondary. So for someone who's aging into Medicare, to work with their agent, and the member might need to research with their employer, what size company do we have? If I am eligible for Medicare, how would my claims get processed? Or just kind of do their due diligence. And again, work with their agents to figure out how their coordination of benefits would work when they're aging into Medicare.
Those can get really dicey if done incorrectly. So if you're having that discovery process with your client, make sure that they know this information or get this information in front of them so that they know what to sign up for. So real quick knowledge check, like I said, if you could just type the letters into the chat, you can type them directly to me or to everyone so you can show off everything you know. So please put the answer that best fits this situation into the chat for me, please. So Blanche has worked as an administrative assistant. There we go. For most of her career, she'll be turning 65 2 months from now and is not yet receiving Social Security benefits. She's unsure whether she will enroll in Medicare Part A. Which of the following reasons might help her be convinced to enroll? Yep. All right. So everyone who answered me got it right. Yes, the correct answer is A. Part A is for hospital stuff. So B and C, those are probably those, you may or may not get that premium free stuff depending on what you sign up for, but those things are not covered in Part A. Those are the only thing that'd be in Part A here is the hospital stuff. Doctor visits and vision dental benefits are usually in Part B and or C, depending on which item you're talking about. So let's jump into Part B, Medicare. So as you can see, again, our bottom of our pyramid, Part B, starts us off with the rest of the coverage. So most, because I said before, most of your, well, really every Part C and Med Sup, you need to have A and B to get those. So make sure that your clients have those before you get started in anything else. So now let's talk about the Part B, the doctor portion of our show. So beneficiaries can purchase Part B even if they're not eligible for free Part A. Part B premium is always charged on a monthly basis. Premiums can and will change every single year. The base premium this year is $185. And there is now a reduced premium for immunosuppressive only coverage, which we'll get a little more into later. We talked about FICA taxes before for Part A. That is not a thing for Part B. So no need to get worried about any of that. The immunosuppressive only coverage amount in 2025 is $110.40. If your client is interested in that, we'll talk a little bit more about what that means in a moment. So for Part B, with your premium, some of your clients might be subjected to something called IRMA. Before I was working in health insurance, I thought IRMA was just a hurricane. It is not. It is also, I mean, metaphorically, it can be a hurricane for some of your clients. So if a member has it's called a modified adjusted gross income reported on their IRS tax return from 2 years ago above a certain amount, the beneficiary will pay a standard premium amount, that $185 in 2025, and an income-related income-related monthly adjustment amount as well that will be added onto that premium. This has been around since about 2007, and these income-related monthly premium rates affect about 5% of people with Medicare. So you're probably not going to see this a lot, but it's a good idea to have like an idea of what's going on. And you can look it up later if you need to. So no need to like memorize it or anything. Your clients can dispute this charge if they want to. They can call Social Security number on your screen to do that if they so choose. I know that like that was really high level. So let's just look at the chart. I think that's easier. So this is how IRMA is determined. So the IRMA calculations are for 2025 here. So you'll notice on the left-hand side, we're looking at tax filing status for 2023, and that will determine the IRMA status for that person for 2025, for this year. So you'll see if the person makes $103,000 or less, then they have no IRMA. They're just paying that $185 for Part B. And then as their income increases and goes down the chart, again, there's different numbers for if you're married or not, the higher the IRMA amount is added to your premium. So again, you're paying that premium and IRMA. So if you're trying to calculate in advance, you would have to calculate for the increase in the premium and then the increase in IRMA and add them together. We have a couple of videos on that on YouTube, and there's a Part B calculator as well you can use for your clients if you so choose. So you don't have to memorize this chart or anything, but same thing, if just to have an idea of what's going on. So Medicare Part B, what does it cover? We talked about how we pay for it, what it costs, what's it cover? So Part B helps cover medically necessary outpatient services and supplies such as doctor services that are medically necessary, outpatient and medical surgical services for supplies for procedures like x-rays or stitches or something like that. Clinical laboratory services like blood tests, urinalysis, and some screening tests. Durable medical equipment like walkers and wheelchairs, diabetic testing supplies. Preventative services like exams, tests, screenings, and some shots to prevent, find, or manage a medical problem. such as your flu shot, your yearly wellness visit, home health services, and Part B pays for home health services if inpatient hospital stays don't precede the need for home health care. If you look into the chat, oh, Renee, I think you gave that just to you and I. But if you take a peek into the chat, Renee has provided some, I just accidentally moved slides. I do that once a webinar. I'm so sorry. But there is a little more information on how, on what exactly is covered and what isn't in a booklet called Medicare and Home Health Care. And you can check that out and they can give you a little more information on the details of those things. But again, this is just like your overarching. So if you need to look at the details, they are there for you. So there's also a slew of covered preventative care services provided by Medicare, but be aware that these are not the same as what is mandated by the ACA for non-Medicare plans. So this is going to feel familiar to those of you who might have came from the individual under 65 market, because I always think of them in my head as like the 10 Medicare or the 10 under 65 commandments, or the 10 ACA commandments, the 10 things that have to be covered. For Medicare, that list is a little longer. I'm not going to read them all to you, but they are there for your viewing pleasure. I like to often point out the importance of highlighting that welcome to Medicare visit or the annual wellness exam, because that's where the provider is going to give you a lot of those things that are covered under your Medicare care. So if you're going to sell Medicare, make sure that you are getting your clients to that welcome to Medicare physical exam. They can help catch a lot of this stuff, and it's covered. It's free. Why not? Okay, so what are our costs for 2025 when it comes to Part B? So in addition to the premiums that we talked about earlier, there are some other costs you will pay in original Medicare. The annual deductible in 2025 is $257 If you have original Medicare, you pay the Part B deductible, which is the amount a person must pay for healthcare each calendar year before Medicare will start paying for you. As we said before, this amount can and does change every year. Coinsurance is a thing for Part B services as well. In general, it is 20% for most covered services for providers that accept assignment. That's a big one. Accepting assignment means that they will charge what Medicare agrees to pay. So it's another thing to keep in mind and make sure your clients understand that if they want to go to a doctor, make sure that doctor accepts assignment. So for example, a member pays 20% of every doctor visit after they've met their annual deductible, and there's no limit to this 20%, and there's no out-of-pocket max. Durable medical equipment is covered at 20% as well. And then most preventative services do not have coinsurance because they have to be covered, like on the slide from before. We talked about accepting assignment already. But keep in mind that if they don't accept assignment, that means that they can charge up to 15% above the approved amount, which is called a limiting charge. And you might have to pay that entire amount up front, depending on how the provider wants to bill you. So I always just say be safe and just tell your clients to make sure that you have a doctor that accepts Medicare assignment. That way you don't have to worry about any of that. Okay, so late enrollment penalties as well here. So if you don't enroll in Part B when you're eligible, your monthly premium will go up likely 10% for each year. You could have signed up for Part B, but didn't. This penalty is recalculated each and every year, and you have to pay that penalty for life. So say, for instance, the first time you were eligible for Part B was in July of 2023, but you didn't enroll until January 2025. That means you're paying a 20% late enrollment penalty, and that amount will be added onto the original premium and then multiplied by 20% added on. And that will happen for the rest of the lifetime of the person being enrolled in Part B. It will be recalculated each and every time that the premium is raised or lowered, which I've never, rare for it to be lowered, you know? Okay. Last slide for Part B. If your clients are curious if they should sign up for Part B, it's a little more nuanced than Part A. So if your client's already getting Social Security benefits, you're going to automatically be enrolled in Medicare Part A and B anyway. The Part B premium is usually deducted from monthly Social Security, real retirement, or federal retirement payments if your client's getting all that. The amount depends on your income and when you enroll in Part B, as we know because of the late enrollment penalties we just talked about. People who don't get retirement payments or who don't have enough to cover the premiums get a bill from Medicare for their Part B premiums. The bill can be paid by however way you want, really. Having employer or union coverage while you or your spouse or family member, if you're disabled, is still working, can affect your Part B enrollment rights. This includes federal and state employment, TRICARE, active duty military service, stuff like that. I would contact your benefits administrator in your union to make sure if you should apply for Part B or not, because sometimes you should and sometimes you shouldn't, and those are very, very nuanced situations. So it's a little more, like I said before, it's a little more nuanced. And then of course we also have that more and fewer than 20 employees thing that Renee and I talked about in Part A that also applies for Part B. So you want to make sure if you have fewer than 20 employees, you have signed up for Medicare because Medicare will be primary payer. And if you have over 20 employees, it's not as important because that group coverage will be the primary payer. Whew, okay. Renee, did I miss anything before we keep going?
The only thing, Chelsea, I think to add here, important is what we come across sometimes on our individual team is that if a member applies, already has Part A and applies for Part B at a later time, and sometimes when they're sending, the agent submits the application or so, and it might take a little bit longer depending on the time of the year to kind of show up in their system to verify the effective date of Part B. Sometimes carriers will send members a request for information letter or some type of a letter stating they need maybe proof of their Medicare card or some type of proof of the Medicare Part B. And it's good for agents just to kind of remember that to remind their clients, if they receive any documentation, the member at home, to reach out to the agent to get that information back to the carrier. And usually there could be due dates in those letters, but to make sure that they are reading that information and returning that information to the carrier in a timely manner. So that way all the information can be received in time with what the carrier could be requesting.
Right. I remember one of you guys were telling me the other day, like, oh, a lot of your clients are just going to assume because they have a Medicare card that they're just good to go and that might not always be the case. You might have a Part B card still and something might have happened where you canceled it or it's not. Don't just assume because this person has Medicare card, it's 100% ready to go. There's other things that they might need and have that stuff ready, or if they get any letters in the mail from Medicare to look at those. Good point, Renee. Glad you brought that up. Okay, so number 2, now let's check. If you could be so kind as to put in the chat which answer best supports what we're talking about here based on what we talked about just now. So Blanche, our friend again, turned 65 in 2 months. Her family has a history of cancer. She's worried about how she's going to pay for those preventative screenings. She doesn't want, nobody wants to spend money at the doctor's office, right? So what do you tell her? What do you tell her? There's only one correct answer here this time. Like I said, sometimes I sneak up on you and I put multiple correct answers in there. But this time I didn't. There's only one. Okay, someone's got it right. See if someone else gets it right too before we move on. Yes. All right. More than one person got it right. Everyone got it. Yes. Okay, perfect. So Part B is the right answer. Yes, Medicare Part B requires a $0 copay for most preventative services. We saw that big old list on that one slide of all the things that it covers. Okay, we're about halfway done. Supplemental plans. We'll get there. So you might have also heard this be called medigap, and this is health insurance sold by private insurance companies to fill the gaps in original Medicare. Medigap policies can help your clients pay A share of Medicare covered services like co-insurance, co-payments, or deductibles, depending on what, medigap policy they have. Some cover additional benefits that original Medicare doesn't cover. Again, it's going to depend on what plan that you have. Medigap policies don't cover your share of the costs under other types of health coverage, like standalone PDPs or prescription drug plans, employer or union group health coverage, Medicaid, veterans benefits, or TRICARE. So most states have standardized supplement plans A, B, C, D, F, G, K, L, M, or N. So we skip some letters here. You'll find out why in a minute. So they can be more easily compared. They're standardized across almost all 50 states. So that it makes it easy for your clients and really you to shop through these plans, because a plan D is from Blue is gonna be the same as plan D from Aetna, gonna be the same as plan D from Priority. Doesn't matter. Those are always going to be the same. What is covered, at least. The costs might be different. They might add stuff, but the basis is always going to be the same. And the prices are going to change too. So other differences include pre-existing conditions, waiting periods, crossovers of claims for Medicare, administrative contracting policies, and guaranteed issue might be a thing that you have to look out for when getting a Medicare supplement plan. Those kind of details we'll get into in our mastery course, which we will get, I think, 2 weeks from now, is the Medicare deeper dive as to what all those things mean. But for now, that's all you really need to know. So the premium is charged on a monthly basis. It's going to vary by plan, carrier, and location. Like I said before, the coverage is always going to be the same in each plan, but the premiums might change depending on the carrier and where you're at. They are also issue age related and attained age related, and sometimes medical underwriting is applied. We'll talk about all those things in the more detailed version of this course in about 2 weeks. So that's all you really need to know for now. Charles, what do those plans look like? Here's what they look like. You can find this chart just about anywhere, really. The out-of-pocket limits might not always be completely up to date, depending on where you find the chart at, but the benefits and the plans, so the X and Y are going to always, XCs are always going to be the same here. So just keep in mind too, some of these plans offer high deductible versions as well. So that's F and G. You'll see that little asterisk there. And that deductible is down there, or I'm sorry, not deductible. Out-of-pocket max is down there for those plans. So there's a lot of, give you a little bit of a second to take a look at it, but that's the gist. With that chart, like I said, you can find just about anywhere. We will have as well a detailed version on MedSups in 1 week from today with yours truly. So if you want to learn more about those plans, sign up with me next week and we can talk about that. So I'll talk really, really fast about issue periods because we're running out of time here. But essentially, there will be a period where, like your initial enrollment period, where you can sign up for these supplement programs without medical underwriting. That's called a guaranteed issue period. That means that they cannot charge you differently or deny you access to a plan because of your medical history. But after that period of time, you might be subjected to medical underwriting or could be denied coverage or could be charged differently for your coverage based on medical history. That's called non-guaranteed issue. We'll talk a little bit more in detail about that in the MedSup version of our show, but that's really all you need to know for now. Okay, Renee, did I miss anything about MedSups?
Nope, not at all, Chelsea. You're doing a good job.
Okay, good, cool. Now let's check number 3. If you could be so kind as to put the answer in that best fits this situation. Blanche has made the leap and enrolled in Medicare Parts A and B. Good job, us. We convinced her. Looking forward, she'd like to minimize her out-of-pocket costs in the event she needs to be hospitalized. Which course of action might be a good fit for her? Please put your answer into the chat. This one might be a little difficult because I did go through that chart kind of quickly. So I do apologize there. This one always takes longer than I think it's going to give. But the answer is B, just because we're running low on time here. I would tell her to consider a med sup plan depending on, and again, it's going to depend on her location. Oh, you guys are getting it right anyway, so never mind. Depending on her location, because she's turning 65, she's had that guaranteed issue. The sup plans B through N might be a good idea. And again, I know I went kind of fast through those, but we're going to talk about those next week. So stay tuned for more information about med sup plans next week. Okay, Part D. Let's do it all again, but with Part D this time. So Medicare Part D is prescription drug coverage, D for drug. That's how I remember it. If you choose original Medicare and you want prescription drug coverage too, you must choose and join, I should say, a Medicare prescription drug plan, or you'll probably hear me say PDP a lot. You'll notice that in the pyramid there, it's in the middle of the pyramid because you need A and B to have D. But D is kind of like most people use it and need it. So most people will want to have it. These plans are ran by private companies that contract with Medicare. You could not sign up through Part D through CMS. So if someone's trying to get your clients to come to you and like, oh, like the federal government wants me, nope, something's afoot there. Medicare contracts with private insurance companies offering this drug coverage. Everyone with Medicare can get a prescription drug coverage plan by enrolling in a Medicare drug plan. You might pay a penalty if you join later. We'll talk about that in a minute. And you also might have one of these wrapped up with your Medicare Advantage plan. We have not talked about those types of plans yet, but some Medicare Advantage plans do have a drug plan rolled into them. So there might not be a need for your clients to get a drug plan if they have a Medicare Advantage plan. Depends. There is a standard level of coverage that all these plans have to be Medicare compliant. But usually, oftentimes they offer more than that. And then of course, as you get more coverage, the premium rises, right? So it's important to check out what these plans cover drug-wise. So premiums are not automatically deducted from Social Security benefits for Part D, unlike Part B, because they're private. So you have to pay for that on your own. Part D plans are totally optional, but might incur a lifetime penalty if they are enrolled in late. And IRMA does apply here as well. We talked about IRMA with Part B, and IRMA, same thing. IRMA's the same thing with Part D as with Part B. Like, it applies the same way, but the numbers are a little different. So the big difference here, same thing as you can see on the left-hand side. 2 years ago's tax filing status helps your 2025, helps you determine, I should say, the IRMA difference that you would pay. So unfortunately, because there's not one standard Part D premium, it's a little harder to predict how much it's going to cost for your client. It's going to depend on what Part D plan they choose. And then you're adding that amount on the right to whatever plan premium that they choose. And this, I don't know the exact calculations all the time because I'm a health insurance person, not a math person, but they use the average premium for that year to determine as like the basis of the formula. Okay, so cost sharing phases, these are different than they were in the past. You might have heard of something called a donut hole. Back when I first started here, I remember explaining that donut hole to people a lot. That donut hole is no more. Sounds bad. Someone's taking away our donuts. No, it's a good thing, I promise. So there are 3 stages to cost sharing in Medicare Part D. There is the deductible phase. Many Part D plans have deductible, but not all of them. You'll pay the full price for drugs until that deductible is reached. Some Part D plans do not have a deductible, and those plans start in stage 2, the initial coverage stage. So that's the same as it was before. No deductible can be higher than $590 in 2025, but each plan is going to vary, but some might not have one at all. So then you hit up the initial coverage stage. In that stage, copays and coinsurances will vary by plans. Enrollees will pay 25% of Part D, and the Part D plan pays 65%. Manufacturers will pay 10. You'll remain in that phase until your total drug cost reaches $2,000, which is much less than it was in the past. So, whew, this is great this year for your Medicare people with drugs. So then the last stage is your catastrophic coverage. This is new this year for 2025. There is no cost for enrollees once you hit the catastrophic phase. Part D plans cover 60% of the drug instead of 20% like it was in the past. So it's a huge jump, huge difference. Then manufacturers and Medicare cover the other 20%. So great news for Medicare Part D recipients this year. They are going to pay much less for their drugs if they end up reaching that catastrophic phase. So there is a late enrollment penalty, like I mentioned before. If your beneficiaries don't enroll when they're first eligible for coverage or have a break in credible coverage of more than 63 days, they're going to have to pay a penalty. That late enrollment penalty is determined every year and is based on 1% of the average national base Part D premium. Continues for the duration that you have Part D and is added on to the charge for the Part B premium. So kind of similar to Part B's late enrollment penalty. Okay, for those of you who work in group, I'm taking a look at the list. I'm honestly not sure if any of you guys work in group, so I'll be quick about it. And if you have group questions about this, let me know. But doesn't this $2,000 out-of-pocket max thing, Chelsea, doesn't this change credible coverage for my clients? And the answer is yeah, it does. So what am I talking about? So coverage must be as good or better than Part D to be considered credible for those late enrollment penalties that we just talked about. Simpler methods will be used to determine credibility this year than they have in the past. Carriers sometimes have credible coverage charts or mailers, which are available if you can view the link that Renee just so lovingly sent to you. That article reference number, log into your agent portal. Well, I guess you don't even have to log in at this point. You just go to your agent portal and look at that particular article, Medicare Credible Drug Coverage. It will tell you, depending on each carrier, what plan has credible coverage for Medicare and which ones do not. And then clients should also be getting a credible coverage letter from their employer for when they become Medicare eligible. That way they can determine if they had credible coverage for Part D and know if they should be signing up or not. Because remember, if you don't have credible coverage, what are you doing? You're getting a late enrollment penalty, right? So I don't want to spend a ton of time on this just in case the members of our audience don't do group and this doesn't affect them. But there is a YouTube video as well that talks about the changes in credible coverage that we did a couple, like a month or two back. So you can view that if you'd like, or view the article if you'd like the credible coverage charts or mailers, depending on your carrier. If I'm mistaken and there's group agents in our audience, type any questions you have about this in the chat and I will answer them. I just don't want to spend tons of time if you are not a group person. So should I sign up for Medicare Part D? If your client's sitting in front of you, they have these questions. Yes, if your beneficiary wants to avoid late penalties and has no credible pharmacy coverage from another source. Again, make sure that if they are employed and have coverage, they're looking for that letter. And the beneficiary, know if the beneficiary already has credible drug coverage that's at least as good as Medicare's. Whew, okay, Renee, did I miss anything? Thank you for putting those links in the chat for me. I appreciate it.
You're welcome, Chelsea. The only thing that I can think of is, again, going back to when a member's applying, if they are leaving group coverage, members sometimes might get a letter from the carrier asking for a little bit further information about the previous coverage that they had. And again, that information needs to be sent back to the carrier because they could write, they're asking for additional information. So if they have any questions or they receive that documentation, they should be reaching out to their agent too and making certain they know what information is being requested from the carrier at the time. But sometimes we see letters sent to the members when they are leaving group coverage. The carrier might have some additional questions that they need documentation filled out.
Right, just as a rule of thumb, I would say always make sure your clients are just like scouring their mail around that time to make sure they're getting everything. Okay, I might run slightly over the 1 hour mark, and I do apologize for that. I'm going as fast as I can here. For this knowledge check, all of these answers are correct if you were reading it while Renee and myself were talking. All three of those are correct, but I want to make sure I get all of the information out to you. So we're just going to go ahead on to Medicare Advantage, which is the final chapter of our show here. So Medicare Advantage, or you might also have heard of it, we called Part C, is another alternative to original Medicare offered by private companies, but are still bound by Medicare rules and regulations. These plans are kind of like an all-in-one approach to Medicare. They'll combine Part A and B together into one big plan, often with Part D, like we talked about before, and oftentimes they'll be able to include, because they're offered by private carriers, they'll be able to include things like dental, vision, hearing, or other stuff like silver sneaker. We talked about this, other stuff like silver sneakers or transportation. So what is the difference between Medicare originally and Medicare Advantage? Medicare pays a fixed amount to the private carriers that administers these plans. These Medicare Advantage plans have different out-of-pocket costs than original Medicare, and they might have different rules for accessing their services. So that's kind of where they make up, I guess, the cost, is they're just more efficient with, they're going to claim, I guess, they're more efficient with the money, and they can make more bang for the buck and give more things out there. So my overarching advice when we talk about these Med Advantage plans in general is to just keep in mind that each plan is going to be different from carrier to carrier, and even within carriers, there's a bunch of different plans out there. There's tons of plans out there. There's actually been regulation in the past few years to kind of lower the amount of plans that are available to make it a little easier for our clients, but no one plan is like the perfect plan for everyone. It's really, really, really important to take a look at the discovery process with your clients and know them in and out so you can get them their the plan that fits best for them, because that different rules for accessing services part and different out-of-pocket costs for different services, that is so key for planning out which plan is best for your client. So why would a person choose a Medicare Advantage policy then? Because they offer at least the same coverage as original Medicare, plus usually more stuff like PDPs. We talked about all these before, and they get one card, one bill, one explanation of benefits. Usually it's more simplified and easier for your client to navigate. Oftentimes at zero premiums too. So just to be quick here, all of these things are true. Medicare Advantage plans often cover dental, vision, hearing. They often offer PDPs, prescription drugs, and they have one bill, one card, one explanation of benefits. So, how and when can you enroll in Medicare? I have 1 minute left, so I'm just going to show you this instead of talking about it forever. We will talk more about these different periods in the Medicare expertise version of the show in about 2 weeks. So you might have heard me say a couple of these already before, like your initial enrollment period. That's when you first are able to first turn 65 and are first able to, excuse me, turn yourself over to Medicare. You might choose not to do that at that point, but that is usually when a lot of people jump in. A special enrollment period is another one you're going to see a lot. Because that might be when someone quits their job and then can get onto Medicare, or maybe they move, or we'll talk about it in the expertise version of the show. And then AEP is the one that if you celebrate, this is the time where Medicare Advantage, people can change their Medicare Advantage plans. That's the big one. And then we are currently right now in the MAOEP, which is where we like to call it a once lifetime change to a Medicare Advantage plan. I'm hyper simplifying this, but again, we'll talk about it in the expertise version of the show. Oh, so I understand if you need to leave because it is 11 o'clock. I tried my best to get it done in the time. I got a little over. So essentially in this slide, this is just telling you when someone might automatically be enrolled in Medicare. This is if you're getting Social Security benefits already, if you're under 65 and have a disability, or any age that you have ALS, you would get enrolled in these things or in Medicare. If that is not the case for you, then you would enroll during your initial enrollment period, which is 3 months before turning 65, the month you turn 65, and 3 months after. If you do get diagnosed with ESRD, we mentioned that's another way you could get Medicare. You would have to contact Social Security to let them know that happened so you can sign up. Okay, sorry I had to blow through those last couple slides so quickly. If you have any questions about them, please let me know. Type them in the chat and I can get them to you. That's about it for this. I'm sorry I had to go so fast at the end, like I said. If you have any questions, let me know. Renee, is there anything you would like to share, add, tell our audience before we get going?
Nope, thank you for everyone who attended today. And if you have any additional questions, please feel free to reach out to your account manager, or you can reach out to our individual team, email us, call us. We're happy to help. And thanks again for everyone who joined us on this webinar.
Love gushing about the individual team. When I'm in this room, I can almost see them. They used to sit right next to me and I miss them dearly. We shuffled our office around recently and they're not near me anymore, and that makes me sad, but I do visit them from time to time. So give them a call. They're helpful, wonderful people. Join us next week when we talk about med supplement plans. And then 2 weeks from now, we have the Medicare expertise webinar where we talk a little more about those enrollment periods and all the rules regarding all of those. But thank you for spending time here with me today, and have a great rest of your day and happy Valentine's Day.